Well, welcome everybody. Just to let everybody know that this webinar is being recorded, so this will be available for viewing following this meeting, this webinar, and ahead of a follow-up meeting, which is on Wednesday next week. And the purpose of this webinar is to explore the challenges that may be involved on living with the diagnosis of CLL and watch and wait or active monitoring. How can we make this better? How can we better cope? And we have a terrific panel with us to actually cover these different topics. I'll just introduce myself first. It's a 60-minute webinar, and we'll try to keep to time for everybody, bearing in mind people seem to be joining late. My name's Nick. I am a CLL patient myself. I've spent some considerable time myself some years ago on watch and wait and active monitoring, and I work in the advocacy department for leukemia care and wear a few other hats. So I'm myself quite experienced in these areas. So this is a topic that's very close to my heart. And welcome on what is World CLL Day today, which is a great opportunity for us to look at these topics to help people to be able to manage and cope better with these specific challenges around general health, managing general health, emotional and psychological well-being, whilst you're in a period of uncertainty and what feels like being on hold. And the topic of World CLL Day today is actually around the same topic, is understanding mental health challenges and ensuring that these are met along your entire pathway. And as we know with watch and wait, this isn't just a stroll in the park, and it can be for quite some time. And there are many uncertainties involved in this. So I'm pleased to be here today. It really is a pleasure. And with that, I think without further ado, I'll just allow our different speakers to introduce themselves. So if I start with yourself, Helen, would you be able to?
Thanks, Nick. It's a pleasure to join everyone today. My name's Helen and I work as a CLL nurse specialist, and I'm based in Nottingham. And that's a role I've been doing for 10 years now. And we've just expanded our team to 2 of us so that, you know, the workload has increased so much that it's enough for 2. And I think the CLL nurse specialist role is gradually growing, I think, and there's getting more and more of us that are specific for CLL. So I'm going to give my nurse perspective really of what we can do to help today.
Thank you, Helen. And if I recall, you were the first CLL specific nurse specialist. Yeah. So, wow, things are coming along. Mike, please introduce yourself.
Yeah, hi. So my name is Mike Norris. I'm a senior psychological wellbeing practitioner with NHS Top Therapies in the Durham and Darlington area. I specialise in working with patients who have comorbid difficulties with long-term physical health conditions and the impact that has on their mental health. So while I'll be offering, hopefully offering some kind of some sort of wellbeing exercise and techniques and signposting for psychological support, I'm hoping to learn quite a lot myself today. So thank you all for having me. I really appreciate it.
Thanks for the intro, Mike. Just a little flag. When we were chatting during the chat before the start, your mic seems to have depreciated slightly. You've got a little bit of a robot-y type of echo going on there. You might just need to turn it up or get closer to it. No. So with this, may I hand over to you, Scott, to introduce yourself and start with your talk? That would be a terrific way to proceed.
Sure. So hello everyone, what a pleasure to speak to you all on World CLL Day. I'm Scott Marshall, haematology consultant in the North East at Sunderland. I've got a special interest in CLL, and hopefully I'm going to demystify some of the things about CLL today. So we'll get on with things. Just share my screen.
Whilst you're sharing the screen, just from an agenda in terms of sequencing, Mike will give his talk as the haematologist, providing an overview of the rationale for why watch and wait or active monitoring, why it's used, and looking at some of the challenges and some of the explanations. And then Helen will follow on with her talk as the clinical nurse specialist and key worker, and the role of the key worker and how your needs are met and how you are supported to make things better. And then we'll be followed with a talk from Mike, who is our wellbeing practitioner, to explore practical aspects of managing and coping with many of these issues and uncertainties, and using wellbeing initiatives that may maybe have helped you, as well as explaining why some of these emotional and psychological issues are experienced. Sorry to cut in on you there, Scott. We can see your screen now, so I'll let you proceed.
Brilliant. So I'm going to try and cover this as an agenda today. What is CLL? What to expect? Why no treatment if my disease is at an early stage? And what can you do for yourself? So the first thing that I'm going to say is, whenever if you've been diagnosed with CLL, information and understanding is one of the crucial things for helping you cope with what you've been told. Now, CLL is, although it's the commonest leukemia, it's still a rare cancer, and certainly not in the ballpark of the more common ones like breast cancer, lung cancer, etc. So finding good information is important to help you. I put this slide up because it includes the generic NHS information, which I have to say isn't brilliant, but we have all these specialist associations that support us in CLL, Leukaemia Care Today, but also the UK CLL Support Association, Bloodwise, Macmillan, Cancer Research. These are all very good sites where you can go and read about information and rely upon what you read. Going along with that, you know, most doctors don't have extensive knowledge about CLL. Even some haematologists who don't focus on it, they will always have an understanding, but perhaps not in-depth knowledge of CLL. So don't feel frightened to ask questions, come to forums, ask advice groups about what's happening to you. And if you feel it's not right, to ask those questions and get clarification. We try very hard to make sure everyone's educated, but of course, it's sometimes difficult getting to everybody. So chronic lymphocytic leukemia, it's commonly brandished as the most common leukemia in the Western world, 1% of all cancers in the UK, and it gets more common as you get older. We get about 100 new cases per year in the Northeast, about 3,500 new cases in the UK, but the majority of those are caught at an early stage and don't require any intervention. So how do we make the diagnosis? Well, this is a typical blood film of what we see, where when we see high white counts on your blood tests and we see too many of these lymphocytes, and what CLL is an accumulation of these non-functioning lymphocytes that upset how the bone marrow works and upset how the immune system works. Exactly what goes wrong, although we've got lots of understanding and know much more these days, we still don't know all of the detail. We do know that traditionally cancer used to be thought of as cells that just live forever, but now we know that actually there's an environment that they like to live in, and to survive, they need signals from that environment. And some of the treatments that we use these days looks to block those signals. And that's what we talk about with targeted therapy. And the established risk factors and who gets it, it's still being unraveled. And we believe that rates around the world are probably similar. And when we do see differences, it's probably more to do with how data is captured rather than there's a genuine difference. So this slide is quite crucial to you because it shows for the diagnosis of CLL, more than 80% of people, it's found as an incidental finding on a blood test that's performed for other reasons. So nowadays, in particular with healthcare the way it is, we do an awful lot of tests. So don't be surprised if inadvertent things are captured. Then the other things that go along with it, lymphadenopathy is the name for enlarged lymph nodes. Splenomegaly is one of the organs in your tummy that can get large with this disorder. Symptomatic anemia and thrombocytopenia, that means low hemoglobin, low platelets. That's Hemoglobin's the stuff that carries oxygen around your body. Platelets are the things that plug holes and stop you bleeding. So sometimes those go low, and that's evidence that the bone marrow that makes those cells isn't working properly. The immune system can be disrupted, and some people get troubles with infections. Some people, I know it's a real minority, when they have a lot of CLL disease around, can get what we call B symptoms, which are covered as fevers, unexplained fevers, not explained by infection. Sometimes they just happen at night and are more like night sweats. And then loss of appetite and losing your weight, but that's a lot of weight, 10% of your body weight. There are some people who just have unexplained symptoms, such as profound lethargy, and we don't have any other explanation other than their CLL disease that looks bulky on our investigations. And for some, we find that when we treat it, those symptoms get better. But just feeling off on any particular day is not evidence that your CLL is out of control. The diagnosis of CLL, well, in the past, doctors very much relied on simple measures like looking down microscopes and examination and things. But nowadays, we've got very specialist tests. We call them cell markers, and we use these cell markers to make a diagnosis of CLL. We're looking for very specific things, which is summarized on this slide. I'm not going to go into the detail, but nowadays it's a very positive and robust diagnosis. Okay. We cause confusion because sometimes we talk about chronic lymphocytic leukemia and sometimes we talk about small lymphocytic lymphoma. This is because how doctors used to classify the different forms of lymphomas. We've, as our knowledge has expanded, we've reclassified, and now we know that CLL and small lymphocytic lymphoma are basically the same disease, but just presenting in different ways. So there is no difference in the way this is managed. We just call it CLL when we can see the lymphocytes in the blood, and small lymphocytic lymphoma when the predominant problem is enlarged lymph nodes without evidence of the disorder in the blood. Staging, you'll always get directed to staging, and there are two main systems that are used, Ryan Binet. The crucial thing here is people always talk about the number of lymph node areas where we can feel lymph nodes, and lots of clinicians get this wrong. So you are stage A or early stage CLL until you've got lymph nodes in multiple areas. And we define those as neck, under the arms, under the groins, and then big liver, which is hepatomegaly, and big spleen, which is splenomegaly. Now, crucially here, if you've got lymph nodes on both sides of your neck, that still only counts as one area. If you've got lymph nodes on only one armpit or the other, or both armpits, that still only counts as one area. Similarly with the groins. So a lot of people that are sent to me, I'm told that they've got more advanced stage CLL, but when I see them, actually they don't credit for that. We're not here to talk about treatments for CLL, but I put this slide on basically to say there are loads of treatments for CLL these days, but in the early stage, none of them have shown benefit, as I'm going to talk about now. And the criteria that are used for treating CLL and where we show that our treatments really make a difference are summarized on this slide. So it's bone marrow failure, where your blood counts are low because the bone marrow is failing, or because you've got a great big spleen that's either causing you discomfort or causing problems, great big lymph nodes that are either, again, causing you problems or are very large in size, or that we can see in your blood that the CLL is progressing at a really rampant rate. Within a couple of months, it's increasing, whereas For most CLL, it doesn't do that. It slowly progresses over months and years. Sometimes because the immune system is disrupted, we can see funny scenarios where the immune system turns against your own body cells. That's what we call autoimmune. And again, those names, anemia and thrombocytopenia, low hemoglobins and low platelets. And then last of all, when people just have these symptoms that we can't explain in other ways, and we think CLL is looking bulky, and it's probably the answer. The next 3 slides I'm just going to flick through, and they're really to show that when clinicians are assessing you, there's a lot of different things that we're looking at to try and decide upon your best therapy. So I'm not going to go into this today, but one thing I certainly do want to point out is CLL is predominantly a disease that gets identified as you get older. And what we're trying to educate clinicians these days is we're all living longer, and therefore people need to have a very good assessment of your likely prognosis when they're making assessments about your treatment. So that's how long you're likely to live even without the CLL, so that we understand about your body. A crucial part, though, is we take on board how good your body is, what organ failures you've got, how fit you are, how active you are, what you can manage within your capacity. So one of the main things that you can do is keep yourself healthy. For a long time, people used to talk to patients with CLL and say, oh, it doesn't matter, this CLL, people live out their lives normally. We know from studies, people do, it's recognized that CLL has an impact on your lifetime prognosis. But of course, if the diagnosis is diagnosed in your 70s and 80s, and it's behaving in a very slow-growing, indolent manner, unfortunately, nature may have other ideas for you long before you're ever troubled by the CLL. So there's quite a variability in what happens to different people, but the CLL should be actively managed, even if that active management is no treatment. So when we look at CLL and we judge that you're at an early stage of disease, there is no benefit in early treatment that I'm going to talk to you about in the next few slides. So the gold standard of treatment at early stage CLL, if you're living in harmony with it, is no treatment, which someone really cruelly came up with the term watch and wait somewhere, which just gives the whole feeling of impending doom, waiting for something to happen. And I prefer the term active monitoring. Some people talk about watch and worry. It's a terrible term, and we should try and get rid of it. To give you an idea of the timings and how doctors should assess this, we need to establish how your CLL is behaving. There is a small proportion of people who can have nasty, more aggressive CLL that needs intervention sooner. But for the great majority of people, no treatment is needed for months and years. So in the first year, we take blood samples every 3 to 6 months and assess you every 3 to 6 months and see how things are changing. And if it's not changing at any rate, then that monitoring may well be taken away from hospital care and put back to your GP, just depending on how your local services are set up. And it doesn't matter whether monitoring is happening, as long as there's good communication between the services, so that if it gets to a stage you need interventions, then all things run smoothly.
Scott,
Yes.
Sorry to interrupt you. We've identified an issue, and I'm not sure how this has happened. It would appear that a large proportion of those registered for the event have got the 3:30 time, and it looks as if there are different timings in different channels.
Okay.
So you inadvertently, if we look at this as a positive rather than a negative, not wishing you to repeat yourself, but it looks as if a lot of people are going to be joining at 3:30. So You have a little bit longer for your talk when you're summarising different aspects of the rationale for why watch and wait, why active monitoring. I thought I would just flag this, and I would flag this to the audience. I understand if audience that are looking to join, that have joined at 3 and may have to leave at 4, this might be an issue. But I think there's going to be a large number potentially joining at 3 o'clock, at 3:30. I just wanted to flag that to you. If we keep an eye on numbers of people joining, as the moment we have 17, and I know 100, around about 100 have registered, so we would normally expect to have about 60 out of 100 registrants attending. I just thought I'd flag that to everybody.
Do you want to go back to the beginning?
I think if we keep an eye on the number of people and the number of people, I don't want to interrupt your flow because it's a terrific talk, but just if we suddenly get an influx of everybody at 3:30, might just ask if you could just summarize what went before. Apologies to everybody in the audience if you have to hear some of those summaries again, but that just gives us a little bit of leeway.
Okay. So this is looking behind some of the evidence of why we believe watch and wait or active monitoring is most in your interest. So we've had various different agents for treating CLL over time in one of the previous slides that I showed you, and the development in therapies as they've gone along. And while we've had different agents, people have always been keen to try and get in treatment earlier if they think it's going to make a difference. So it's been tested in multiple trials, of which this slide just summarizes some of them. So in the early days, we used to use a lot of a drug called chlorambucil. Then we found a new drug called fludarabine that seemed to be much more potent against the CLL. And then finally, for a long time, we lived with the knowledge that a combination of traditional chemotherapy called fludarabine, cyclophosphamide, and rituximab, the rituximab helping to engage the immune system, was the gold standard therapy of treatment, and what we've treated a lot of people with CLL over time. And what we could show in all of these treatments is at the point of needing treatment when the CLL was out of control, these treatments definitely improved both people's living standards and their survivals. But when these treatments were tried early, before the disease got to the stage where it was compromising the body, we've never been able to demonstrate an improvement of survival. So early treatment does not improve overall outcomes for patients, but not only that, can have harmful effects that we weren't expecting, and therefore using the drugs early is not thought to be in patients' interests. And that's carried on even to the most novel, what we call targeted agents, where we believe these agents are much less toxic than traditional chemotherapy, but still in large trials where they've been tested, and this trial was only reported in the last year or so, using ibrutinib, a BTK inhibitor, a targeted therapy for CLL, still has not shown improved survival and long-term outcome. And because, like any treatment that we use, there are always side effects that go along with it and risks of damage that come from any treatment. So we have not shown benefit of early treatment. So it is an active decision not to give treatment to patients when they're in the early stages. This next slide I just show briefly because if you do look at any medical literature, it's very easy to see graphs like there are on this slide where it appears that event-free survival, which means that when we treat the CLL, we get rid of what we can see, and how long do patients go before we can see it again? And what we do know is if we give a treatment, we do get rid of the disease, and it does take longer to come back or progress. But when it's compared for survival and long-term outcome, we don't see these benefits. So don't be confused when trials report, particularly at early stages, and appear to show better disease control, but it doesn't lead to long-term better outcome. So to give you an idea of what to expect, people have always thought about, are there ways where we can identify who might need treatment sooner rather than others, those with more risky disease than others? And various things have been looked at with complex tests or just simple examination and monitoring. And still, this is the international prognostic system that has been shown to be the most reliable. And it relies upon three things. So it is a gene test called this mutated immunoglobulin heavy chain genes. And we've known for a long time, since I was at medical school, that if you test for this, and there are two results, the CLL is either mutated or unmutated, and that represents the stage of development when the lymphocyte cells go wrong in making the CLL disease. And this, whether or not it's positive or negative or mutated or unmutated, divides the disease into two groups. So if we combine that test with people who have lymphocyte counts more than 15,000 or 15 times 10 to the 9 per litre, as it's more normally described in hospital blood tests, and then those who have detectable enlarged lymph nodes, and we put all of those three into a score. If you have mutated CLL with no lymph nodes and a low lymphocyte count, hardly anybody needs treatment within 5 years, less than 10%. If you've got one of those risk factors and only one, 3% of people at a year, so again, a very, very small proportion will end up on treatment. And if we look at 5 years, less than a third. So still the great majority of people go a long, long time before we need to consider treatments. Even if you're high risk with 2 or 3 of these factors, still only 2/3 of people are treated at 5 years, and only about 1 in 8 people are having treatment at a year. So the real reassurance here is CLL does not move quickly in the great majority of people. There are other things that we need to take into account when people have got CLL, because it disrupts the immune system and has other effects. So people can suffer with infections. Sometimes the immune system can turn upon yourself, a thing we call autoimmune complications. Sometimes organs can get big, which cause low blood counts for a different reason. So there are still things that need to be watched out for, and doctors need to appropriately manage. Of course, giving anybody a diagnosis of cancer causes a lot of psychological distress, but to me, cancer is a cruel term here, because it's one that in our lives these days, cancer is a real fear term, and really harks back to nasty cancers that grew quickly and caused the demise of people with a lot of suffering. CLL, for the great majority of people, is a much slower growing disorder that you can live in harmony with and get on with your life. So from the great majority of people, it's learning to live with your CLL. We can't get rid of it. We can't just take it away, but it does not need to ruin your life. And in fact, it's often the anxiety around having been told the diagnosis that can ruin your life far more than the actual disease. Second cancers, we do know that other more common cancers like lung cancer and bowel cancer and things are a bit more common in people who've got CLL, but still rare. And what we say is you should still go through the standard recommendations for either screening for cancers, or if you get symptoms, don't ignore them, go and see your doctor and get them investigated. For a small proportion of people, sometimes the CLL can turn into a more aggressive form of lymphoma that we call Richter's syndrome. that needs very different management. And again, so if you get lymph nodes that suddenly start enlarging at a much faster rate than in other areas, you need to see your doctor. Leukostasis is a term where the blood can become thick because the blood is full of cells from the leukemia within it, and it becomes too thick to get through your blood vessels. It's fantastically rare in CLL, and really only when your lymphocyte count is above 400, and even then very rarely. It's not a straightforward indication for treatment of CLL. People can live very happily with high lymphocyte counts in their blood, but it is something that doctors have to take notice of. I've told you that the immune system is weakened in CLL, so vaccination is an important armament against trying to protect people. But vaccination is used a lot in all sorts of disorders, and there are various different ones. One real breakthrough that's come forward is the new shingles vaccine. So there's general advice we can't give live vaccines to people with CLL because of that compromised immune system. So the old Zostafax vaccine for shingles we couldn't give to people with CLL. In truth, there are many people who had it and never had any problems, but there has been occasional patients that have come to harm, and so there's general advice out there not to use it. This new Shingrix vaccine is a dead vaccine or non-live vaccine, and is safe to use in CLL, but not only that, it's just much better. As of July of this year, NHS England have agreed to fund this vaccination, and there's a programme to get it. So in the past, vaccination was only available to those over 70 for shingles. Now, if you've got CLL and you're over 50, you can have the vaccination, and I'm sure in time will get given to just everybody. So vaccination generally is a tactic in helping to protect people with CLL and protect them from infections. We recommend everybody has annual flu vaccines. A common infection in the community that can cause chest infection is called pneumococcus. We can vaccinate against that, so we recommend it in people with CLL. There used to be another one called Haemophilus influenzae, but that's less problematic these days, and we no longer recommend vaccination for that one. If you're going traveling abroad, many of the vaccines that you're offered are live vaccines and quite dangerous. You mustn't have any of those. The Shingrix vaccine for shingles is important, and I've put deliberately COVID vaccination last on this list. So we now know that even patients with CLL respond very well to the multiple vaccinations and the current novel vaccinations that we've got for COVID. So no longer do people with CLL need to live in fear of COVID, which they have done for a long time. So please make sure that you do have your COVID vaccination. It's not to say you won't get the infection, but it's life-threatening consequences and now very rare to see. General health advice. If you do unfortunately suffer shingles, there are tablet treatments that can help. You should have them long term. For what I just said to you about cancers, you should definitely avoid smoking. You should take care in the sun for skin related damage and skin cancers, and you should try to keep yourself fit with general activity. That's good for the mind, and it's good for your body in general. So this is my final slide to try and help you live with things. It's get good advice, use good information, and understand what you've got. Go out and ask questions when you're unsure. There are lots of support around. CLL has a spectrum of disease, and you have to find out where you sit in that, but treatment is only needed at the stage when the disease is out of control. The aim of management is not to cure, it's to help you live with your CLL. We know a lot about CLL, and we're finding out more over time, and who knows what the future holds with treatment and potential cures of the future. Treatment options have massively expanded and the treatments are much better now than they ever were in the past, and we keep working hard to make them better and better. So what can you do? Optimize your health and fitness, keep your body good so that we can offer you those treatments when it comes to your turn if you need it. Try and manage infections by being proactive with things like vaccination. And most importantly, listen to today, try and respect your CLL without fearing it and make sensible health choices while continuing to make the most out of your life. You only get one. Okay, and I'll stop at that stage.
Thank you, Scott. And I hope your throat isn't too sore. I really appreciate the fact that you've actually gone over the first part of your talk again. Really interesting, and a few questions have arisen from those. Hopefully, if we've got time, we can touch on those. I guess it might be easier just to quickly deal on the one that's popped up that I wanted to just ask about was the frequency for pneumococcal vaccination. There's a question about that, and as you touched on vaccinations and vaccinations in general, my understanding is that you know, patients are encouraged to make sure early on in their pathway or journey, for want of a better word, to make sure that vaccinations are all up to date. But how frequently should somebody receive their pneumococcal vaccine?
So it is on this slide that people can refer back to, but there are different vaccines out there for pneumococcus, and you need certain ones.
Okay.
So your doctor should have the information on that, and your specialist should be making recommendations if they're unsure. It follows national guidance, but basically for most people it involves having one extra injection if you've never had it before, which most people have during childhood vaccinations and things. It needs 2 injections. In times gone by, and for certain conditions, for example, if you've had your spleen removed, reboosters are recommended every 5 years, but not for CLL. So once you've had it once, you only need it that once.
Okay, that's clarified that question, and I think time permitting we can touch on some of the other questions, the finer questions with regards to early CLL, and there's a question there about MBL stroke CLL, what is which. Hopefully we can come to those later on. Listen, everybody, really appreciate your patience. It's great to have everybody together today. With this, could I lead into Helen and to allow you to introduce yourself again, Helen, and your talk with regards to your role and the role of the key worker and how you provide day-to-day support and care management to help patients live with active monitoring.
Hi, good afternoon, everyone. It's a pleasure to join you today and be asked by Leukaemia Care to join you. My name's Helen. I work as a nurse, a CLL nurse specific, really, specialist in CLL in Nottingham, and I've been doing that role for about 10 years now. So I've seen how things have changed over those 10 years, which has been huge, really, and it's been a pleasure to be part of it and see how things have moved on for patients and to improve patients' care. Next slide, please. So I was just really briefly going to talk and reiterate really what Dr. Marshall said and how a nurse specialist can be there to help improve things for you and give you information and guidance along the way. It's a difficult path for some, and others amaze me how people cope with it, really. And whatever we can put in place to help, we will do. And there's no one size fits all really for everyone. Everyone is very, very different. So I was going to touch on the main concerns that were highlighted, what's available out there and how you can try and access any support, what helps improve your quality of life during this time, and health and wellbeing whilst you're on watch and wait, watch and worry, active monitoring. I agree that watch and wait is a horrible term, which we need to try and get rid of, but it seems to just lurk there, doesn't it? It stays. So next slide. So I look back really at what Leukaemia Care looked at in 2018. They did a really good project where they did a survey to see what patients felt there, how they felt really about watch and wait and what was missing and how we could try and improve things. So they came up with 6 recommendations, which I thought would use as a good opener really, just to see where we might be falling down and where we could try and improve things. So the things that came up from that campaign was adequate government and NHS planning for cancer care, Timely signposting to resources from trusted sources to help patients better understand the diagnosis and watch and wait, which I think we all strive to do. And actually it's very difficult to get that right for everybody. Improving patient and doctor communication, that can vary as well all over the country, because I think although we're trying to put it that there is one size that everyone will follow a certain process, it does still vary, I think, and we get that feedback when we have webinars like this, that people do see different things depending on whereabouts in the country they are, really, which is sad to see, that it's not at its best everywhere. Guidance for healthcare professionals, so we're all following the same lead, really, to be able to help improve navigation and anything that is available for people that are on watch and wait. Access to a key worker, so that's a term that it could be a clinical nurse specialist or key worker. It could even be your doctor that is your key worker. It varies who that person may be. I think in a lot of aspects it will be a nurse of some sort. And that patients are made aware of support that's available at an early stage. So they were the main things that were highlighted from that study, which we wanted to try and improve from that, really. The next slide. So this is something that I picked up from the cancer strategy, really, that they said that everybody with a cancer diagnosis should have access to a nurse specialist / key worker to help them throughout their pathway, which I think is something that we strive to do and I hope is better, but I think does fall down sometimes. I think our aim is that everyone is aware who their specialist is, and where that isn't happening, there are certain areas such as leukemia care or CLL support who have nurses that are there and available as well, but obviously don't have the insight into your personal circumstances as much as your nurse specialist would do in your own trust or hospital setting that you attend. But there are places that can try and fill that gap where possible. We're there to try and provide as much information as we possibly can, and at the right time. When you have your first diagnosis, it's mind-boggling, I think, and as Dr. Marshall said, about over 80%, it comes as a complete surprise. It's something picked up by accident. You've probably not got any symptoms, and it's found by other means, and not what you're expecting. I think people hear the word leukemia and then don't hear anything else. And then we're piling with more and more information, which you're just not ready to take in, I think. So as a nurse specialist or key worker, we're there to try and drip feed that, really, and reiterate the main points. I think for people who are told they've got this type of leukemia and put on a watch and wait or active monitoring, it's trying to explain what that means in the first place. As Dr. Marshall said, it sounds awful, the diagnosis, but it is a chronic disease, which is very similar to lots of other chronic diseases. Just the fact it's a cancer that seems to make it even worse. To make sure that you have the reputable information that is available. So there is a lot on there. Everybody looks on Google and there's all sorts on there which just will scare the living daylights out of you, which really probably isn't relevant to you. So we're there to try and signpost you to what is reputable and relevant for you, and tailor that to each patient. So we hope you get a relationship with your key worker, really, and you feel able to ask them questions, that you feel that it's open and trustworthy. And it's all very personalised as well. As I said, there's no one size fits all, really. You can ask all sorts of questions that one person may ask, which may not be relevant to somebody else. And we're there to give that information as and when you're ready, really. And to provide that in a written form as well, and reputable websites, such as Leukemia Care. Dr. Marshall mentioned those on his slides as well, so they're all listed. So we've got CLL support, which is very good. Information written by patients as well, which is understandable. We've also got Blood Cancer UK, Lymphoma Action. So there's lots of information out there, which is very patient friendly. Next slide, please. So
Hi, Helen. I just wanted to pop in. Great information so far. Your mic keeps dropping.
Low. That better?
That's a lot better.
It's under the chin.
Yeah.
So what's out there? So there's lots of information and services that are available now, and having seen that over the years, it's just got better and better. So it's just knowing where it is and where to find it and when you want to find it. We know that it's not for everybody for some of these things, but it is out there for you. The charities now offer a huge amount of information and provide webinars like today to give you access to information and advice, which is just invaluable, really. They also offer buddy schemes. So if you wanted to even speak to somebody who's probably in the same position as you, but you may be able to ask questions that you feel you can't ask a health professional because they're not going through what you're going through, those work really well. They offer things like psychological support and counselling. I know at Nottingham we offer that for patients that do need it, but that isn't the case in all centres, but that can be offered by Leukaemia Care, Maggie's centres and things all have support and counselling like that. And support groups, so they're all over the country, or you can join online. I think one of the good things of COVID is that it opened up things like webinars and support groups that were online rather than face-to-face. So it didn't mean that just because it wasn't near you, you couldn't go. So a positive of that is that you could attend those meetings and meet people from all over the country and talk about things and actually realise that you may be having the same issues and thoughts, that there's a lot of other people and you're not alone. Nurse access. So obviously, if you haven't got access to a nurse, you can speak to those through a charity, because I know Leukaemia Care have their own nurse based with them that can cover any issues. Webinars and conferences. I know that you're trying to start more face-to-face meetings as well are now happening for people if you wanted to meet people face-to-face. And as Dr. Marshall mentioned, vaccination advice has become quite a prominent thing now, especially with COVID vaccinations. Having that information there of how to access things, it's not always been very clear, but be able to access that as and when, where to get the vaccinations. I think there's been lots of confusion when you were trying to get vaccination if you had CLL, if you weren't on treatment, some people being turned away. It's really difficult to try and back up that actually, yes, you're classed as somebody who's vulnerable and you should be having those extra vaccines when they're made available. And also with the pneumonia vaccination as well. And then newsletters just to see what's happening in the world, really. At CLL, there's lots of things and it's always changing. Treatments are changing all the time. As you saw on that timeline of what treatments there are available, it has changed immensely and it's just improved people's quality of life over that time. We've gone from using chemotherapies to not really using chemotherapy at all, for long-term treatments to short-term treatments over a year, which has made a huge difference to patients, I think. So it hopefully, and I think it's made our job a bit easier that we have got choices, and actually we hope that you can have the best quality of life possible, and that's what we're there to try and help you achieve, really. And as you said, sometimes the anxiety can be worse than the actual disease, so it is the fear. But if we can be there to try and help allay those fears and give you all the support you need as and when, we'd hope the nurse specialist is there as your constant, really, a constant point of contact. You may see varying doctors over time, but we would hopefully be the one that is there for you all the time. And there as an access point, either by email, by telephone, we can be there to point you in the right direction. We don't know everything. We don't profess to that, but we try and find out for you. I think we've got a knack we want to try and solve everyone's problems, and sometimes we can't, but we'll do our damn best to do that for you, though. Next slide. So just helpful hints, really. I think we've covered quite a lot already from the previous slides, but to make sure you know who to contact and when. A lot of patients don't know who to ask. And it can be difficult. You're giving a diagnosis and you're going to be unwell from other things as well, but I think a lot of people fear, is it because I've got CLL that this is happening, or is it something would have happened regardless? And who do you contact? Do you contact the hospital? Do you contact your GP? Who's the right person to talk to? Regardless, I think nurses will be happy for you to call at any time. If we feel it's not appropriate for haematology, we'll point you in the right direction. Don't be afraid to ask questions. There's no such thing as a silly question. We're there to answer anything. And if you've asked it before, don't be scared to ask it again. It doesn't matter. Ask as many times as you want, really. We always say, if you come to appointments, bring someone with you. Another set of ears is always good. They may take away something that you didn't pick up on, or just remember it in a different way. So if you can do that, I know during COVID that was difficult, but that is getting easier to do now. Write things down. So it may be your appointments can be quite far apart, especially if you're monitoring. It could be 6 months apart, even yearly. And over that time, things are going to crop up. But if you feel it can wait, just write it down and bring it with you. Don't feel like you've got to wait. Even if you feel you want to ask it, you just contact somebody to speak to them and ask them that question. And as Dr. Marshall said, a healthy lifestyle, really. If you can just do the things you enjoy, really, isn't it? It's keeping some mentally, really, as well. We find psychologically, yes, this is hard, but if you can keep up with the things you enjoy, you don't need to isolate yourself. Set yourself goals that are achievable to try and help when you are finding things difficult. And if you are finding things difficult, you're not failing either. It's something that we can work through. There's no right or wrong way of going through things either. I think people try and compare themselves to others, and that's, although it's good to know people in similar positions, it's hard to compare yourself to someone else because you're all going through different things. And especially with CLL, there's no magic number that your white cells need to reach or anything that will mean you need treatment, which I know can then create this sort of uncertainty. But usually the nature of it being chronic and slow growing is that we usually see that coming over a long period of time, and we can try and prepare you for that as and when it may happen. And as we say, it may never happen, but I think that again increases this anxiety. So we're there to try and help you have the best life you possibly can, really, with this in the background, and we can help you as and when you need it. I think I've got one more slide. So I just put a list of questions that we get quite frequently. So a lot of the time people say, what do I need to change anything? What am I doing? Have I done anything wrong? Do I need to do anything different? And that varies from everybody. We just say, do what you normally would do in theory. COVID changes that thing slightly. And in a way, I remember on one of these webinars, a patient said they felt like they were outed a little bit because of COVID, because they then were seen as someone that was vulnerable, which is very understandable, which did mean they had to change things a bit because of isolation. But in a normal world, in theory, it shouldn't change anything. We get asked a lot if we can do anything to slow it down, which we know not really. If we knew, we would definitely share that information, really, but it's doing what you feel you enjoy doing and living a good, healthy lifestyle. Exercise and do what you enjoy. We get asked a lot, do I need to tell anyone as well? And I find that quite difficult to answer because that's very individual from person to person. Who you feel comfortable telling. People say they don't want people to treat them any differently. They don't feel any different. Why should they tell people? And that's very individual. There's no right or wrong there either, I don't think, really. Going on holiday, can I go on holiday? Again, COVID has had a big knock on with that. And travel insurance as well is a real hot topic. We did our support group in Nottingham on Wednesday, and that was quite a hot topic and comes up quite a lot. The price seems to escalate, but people do share good information of who reputable companies that they can then get reasonable travel insurance. And we always say you do need to be covered in some way. It'd be worrying not to have any insurance at all if you were traveling abroad. The impact of COVID we've touched on already. Who should you call and when? As I mentioned, people find it very difficult to know whether they should call the GP or whether they need to ring us. And it's trying to put it in perspective. What would you have done before, really? If you feel it was something that's unrelated, by all means go to your GP. If you feel it's to do with your blood or you've got any concerns with that, then by all means call us and we'll put you in the right direction. A lot of people wonder what is their new normal. We try and say your normal is what it was before, hopefully, and we can then try and help you adjust to that mentally and physically, emotionally, really, psychologically along the way, but try not for it to have much of an impact on you and keep that to a minimum for you. And that was my whistle stop, the nurse perspective of what's available.
Yeah, thank you, Helen. That was right. You've actually done a bit of my work for me as well with regards to some of the signposting to resources, which I will do at the end. I'm mindful of time. I'm mindful that we extended things because of a little bit of a mix-up. There are a couple of questions I'll address towards the end, but one that's jumped out there is obviously somebody recently diagnosed, was diagnosed privately, hasn't had any access to supportive care, clinical nurse specialist in secondary care. Question for both of you, really, because I'm not sure of the processes in this area, and it's something I could also lead on to our advocacy officer, who's available at Leukaemia Care. It's always worth a call to help with connecting you with the right healthcare professionals. But what are your thoughts? I don't know if you've seen the question from somebody here about getting access to a cancer nurse specialist who's been diagnosed privately after a referral that they had to fight for, but has no access to somebody to give supportive care. Are you able to allude on any thoughts, both of you, Scott or Helen?
If I go first, so my opinion, you won't have access to a specialist nurse unless you're referred into a hospital service somewhere, so you get linked in. So if you're diagnosed privately, you should still go and see your GP and then ask to be referred in, and then you can get all of the appropriate support through the local network that will be set up for you. It should make no difference where the diagnosis. I get people referred to me from all over the place and picked up in different ways. You know, if a clinician isn't good with you or a nurse specialist isn't good with you, then you're in the wrong place and find another service.
Thank you, Scott. Anything to add, Helen?
No, I think it's right. Yes, I think even if you've got that diagnosis, go back to your GP and ask to be referred in, and then you should be able to access.
Thank you very much. There are a few other questions that we are able to touch on, but I think it's a good segue now to lead on to Mike, who is our wellbeing practitioner. The messaging in summary that I have so far is that to help with your journey or pathway or living better on Watch and Wait is education and information, quality information. Go to quality information support. If we looked at the World CLL Day, theme of today is that patients need information, support and connection. So that's connection of different ways. That's connection with other patients using support groups or using other resources. Information is key, and obviously access to support. I just wanted to say to everybody, before we move on to the practical talk from Mike about strategies, wellbeing strategies and psychological support, that we are following this webinar up on Wednesday with our national support group meeting for the Watch and Wait group, when we will be joined again by Scott and Mike and Helen's colleague Leanne Palmer of Oxford, so that we can have a proper participative support face-to-face, but virtual face-to-face discussions to explore more. All of the information that has been delivered today will be captured and summarised, edited to make sure it's all together ahead of this session and will be made available to everybody. So Mike, may I introduce you for your very important talk to help with wellbeing and understanding strategies that can help with psychological support.
Yeah, thank you very much. Hope you're not hearing me all right. I know there was some issues with my mic.
You are echoing a little bit. I'm not sure what's happening there.
Imagine it could be the room I'm in potentially, but we'll see. We'll see how we go. Is it particularly bad, or is
it's improved there? I don't know what you've done. If you could lean slightly closer to the mic or something, that might help.
Let's try that. That might be better. We'll see. We'll see how we go. But yeah, just to introduce myself for those who came later. My name is Mike Norris. I'm a senior psychological wellbeing practitioner with NHS Talking Therapies, based in Durham, Darlington, and I work on the long-term conditions pathway. So I specialise in working with patients who have kind of comorbid difficulties with their physical and their mental health. And I think that's really tied in a lot with what Dr. Marshall and Helen have been talking about today. I think a lot of what was something that Dr. Marshall said that really resonated with me is that it's not about living in fear of your CLL, that it's more, you know, it's about living with it and respecting it. And I think that that'll hopefully tie in with some of the things that I'll be saying today. So we'll talk a little bit in general around kind of leukemia and mental health, the vicious cycle, as we call it. I'll explain what that is in terms of that impact that our thoughts, our feelings and our behaviours can have on our mental health. We'll talk a little bit about physical interventions that we can do in the moment to bring that anxiety down. And then just a couple of reflective exercises to kind of put that into perspective. So it's a bit of a whistle-stop tour, but as has been said, you know, I'll be around next week to kind of embed that a little bit more and be able to share best practice and that sort of thing. So I think what I've kind of learned since working on the pathway, and I know, again, this touches on things people have said today, that these words, you know, such as cancer, leukemia, They're very powerful words. They have a profound effect on anyone, regardless of our life experiences. And I think the thing to take away is that, you know, it's perfectly understandable that living with a diagnosis, you know, that is potentially going to impact our mental health. And the thing that I always say to people that I work with is that there is no rule book. There's no right way to feel. You know, when we're kind of going through these kinds of difficulties, people feel that they should be reacting in a certain way, or they should be doing things in a certain way. And you know, again, who would I be to kind of impose that on someone to say, oh, well, this is what you should be doing? So I think it's really important that we find our own way, you know, and that we try to do that and not chastise ourselves too much. You know, if we do have a bad day, that we're struggling, or longer than that. And towards the end of my presentation, I'll talk about kind of the talking therapy services such as my own that you can kind of refer into for support if you feel that you need it. I think what I found that was really interesting as I was kind of researching ready for today was this study from Evans that said that those on watch and wait were as likely to experience depression and anxiety as those in active treatment. And I think a lot of that, the word's been bandied around a lot today, and it's one that I want to touch on as well, is uncertainty, because there's so much uncertainty there. I do really kind of agree with that kind of opinion that watch and wait almost has a very kind of ominous tone to it. It's almost, I'm going to talk about kind of your fight or flight response in a moment. It's almost as if you are a coiled spring ready to react to something that's going to happen. So it makes a lot of sense to me, and particularly kind of getting the information that we've heard today, that really kind of colours it for me, that experience of what it must be like to be on watch and wait. And I think for me, today it's been a real learning experience. Hopefully I can impart some wisdom myself. In our service, and generally in terms of kind of like evidence-based treatments, we talk about cognitive behavioural therapy, and a lot of what we say in cognitive behavioural therapy, while it is a talking therapy, it's very like evidence-based, and we talk about our thoughts, our emotions and feelings and behaviours. In other words, how these can kind of interact with each other to kind of maintain difficulties with our mental health. That's not to say that, you know, if we're having a day where we feel particularly low, that means that we're struggling with our mental health. This is when things are kind of more long-standing and they're having a day-to-day, week-to-week impact on the way that we're living. So in terms of thoughts, I haven't put down specific thoughts there, but it might be around being unable to stop or control worry, particularly with that uncertainty, as we say, of kind of waiting. There might be self-critical thoughts. You know, I think even though there shouldn't be, a lot of the time we can, you know, when we're struggling with a long-term condition, we can beat ourselves up, even though it might be completely out of our control that this is something, but we might start to think about what we could have done or should have done to maybe avoid it. Catastrophizing is a massive one. So for those who don't know, get into that worst case scenario, having that mental image in your head of what's the worst case scenario, and that's what's going to happen. You know, and it can be really scary. It can be a really scary time to, you know, particularly if your mind is prone to race like that. I've just shared like literally a handful of emotions there. I couldn't even begin to imagine what some of those are like, you know, in this situation. But, you know, anger, sadness, feeling scared, uncertain, all of these kinds of things are going to be potentially there in the foreground. That tying in with physical feelings that, you know, perhaps that, you know, if that anxiety is quite high, we're feeling breathless, we're noticing our heart racing, we're noticing low energy. I'll be kind of sort of covering a few more of these in a couple of slides' time. Consequently, a lot of that can have changes in our behaviour. So what we can find is, you know, and I think COVID probably played a big part in this as well, because again, there was that uncertainty of the impact COVID could have, you know, on people with long-term conditions such as CLL. We might isolate ourselves from others, or we might avoid others. It could be due to low motivation, or it could be for fear of kind of leaving a safe environment. In some circumstances, it can lead to kind of poor self-care. We might notice a reduction in appetite, reduction in things like showering, washing, a good night's sleep. You know, these things that we take for granted. In extreme circumstances, it can lead to quite self-destructive behaviour. It could be excessive use of kind of substances, or kind of living life in a way, you know, is as we say, self-destructive. So there's lots of different ways that when we're feeling that adversity and it's impacting us, that it can happen. And that's what we call the vicious cycle. So in other words, the way that we think affects the way that we feel, both physically and emotionally, and that in turn will affect our behaviour. So what services like myself, talking therapies, CBT therapists would look to do is to break that vicious cycle. So for example, we could introduce techniques to challenge or unhook from negative or anxious thinking. We can find ways to, which we're going to get to shortly, in terms of physical interventions to manage the physical anxiety you're experiencing. Other kind of lots of behavioural techniques as well. One I've not really touched on these slides, but we could talk about next week if it's something that's of interest to people, is around what we call behavioural activation. So giving us routine, schedule, pushing ourselves to do the things that we want to do, gives us less time for our mind to wander, for that anxiety to build, and therefore we will feel more fulfilled. But I've focused a little more on these slides in terms of kind of contributing factors and kind of sort of, I guess, rather than sort of interventions that we might do over a period of weeks and sessions, kind of well-being things that you can try and apply yourself. I felt with the time we had, that was the most appropriate. We can have contributing factors that could almost like exacerbate that vicious cycle. So, it could be pain and fatigue. So that could be from the CLL potentially, depending kind of how advanced that is, or it could be just generally. I think people don't realise that when we're struggling with our mental health, what a physical impact that can have. It can leave us absolutely drained. Uncertainty, as we've said, a really big factor for kind of maintaining this cycle and it going round. And of course, external triggers. So this could be, I think it was Helen was saying, sometimes we might think to ourselves, well, should I tell people about this? Or, should I be going on holiday? All these kinds of questions, these fears and anxieties. These external triggers could be like pressure from family who are like, meaning well, but making you think about it more. All of these kinds of things can keep that cycle going round and keep it turning. So obviously, there's plenty of services that can support from kind of a short to long term kind of manner. However, there are other things that we can do ourselves in terms of self-help that would hopefully be quite beneficial. So a lot of this comes down to the fight or flight response. So when we're feeling anxious, and the way that I explain this to my patients is, for those who may not know, back when we were cavemen and we lived off the land and running away from bears and saber-toothed tigers and all this kind of stuff to keep ourselves safe, our fight or flight response is, it's our body's security system. It's what keeps us safe, and we all have it, and it's perfectly natural. However, in 2023 in County Durham, where I am, for example, there's not many saber-toothed tigers around. There's not many bears around, so it's very rare that our fight or flight needs to trigger. Obviously there are situations that perhaps if you were out and there was some kind of altercation or some kind of danger. But what our fight or flight response does is that it reacts in the same way to emotional threat as it does to physical threat. So in other words, the power of these words that we're talking about, so we're talking about leukemia or that uncertainty, these thoughts creeping in, your body will react in the same way as it would if it was confronted by a bear. So things like your heart's racing, that shortness of breath, your mind's racing, a lot of trembling, muscle tension, you might notice sweating. I know that when I experienced panic in my 20s, I used to get a tingling, like a numbness in my extremities. And there's a biological reason for all of that. And I do have some resources that perhaps I could share to explain that it all feels horrible. It's absolutely, that the fight or flight and that panic is really scary. But at the same time, it's your body trying to keep you safe. What we can sometimes then do is have what we call like a catastrophic misinterpretation, that obviously we're living with a long-term condition and perhaps we're noticing a bit of muscle tensions and sweating, a bit of shortness of breath, and our mind can say, oh, this doesn't sound good. Why is my heart racing? Why is this happening? That triggers that response more. So it just kind of goes round and round. So there's things that we can do to manage that. So physical interventions. And I think the number one, and it sounds so simple, is what we call diaphragmatic breathing. And, when I do courses of treatment with people, I try all kinds of CBT-based interventions. When I get to the end and I say to people, what was the most useful? 9 times out of 10, they say diaphragmatic breathing. And that's why I put this here. And again, this is just an advised way that you could do this. Like you know, I might do it slightly differently, but again, it's about finding a comfortable place, you know, closing your eyes, as it says there, one hand on your chest, one on your abdomen. And what you'll notice is that when we're breathing anxiously, it's all from up here. So that's your kind of breathing, because your body's trying to get as much oxygen in as possible to get it into the bloodstream, to get that fight or flight machine going. So if you want to calm things down, it's about slowing down your breathing. It's instead of breathing from your chest, it's about breathing from your abdomen. So it's that inhale through your nose for a few seconds, feeling that abdomen expand. You know, there might be some tension there. That's okay. You know, obviously just do it for how you feel comfortable. You know, you might feel like the 3 seconds feels more comfortable. You know, make it work for you. Hold it for a few seconds and then exhale very slowly through the mouth for the same amount of time. Now, I've heard the number of seconds different in different instances. That's just one example. Again, all kinds of things online. You can make that work for yourself. Another technique which you could do alongside this, or perhaps even kind of instead of this, if you preferred it, is what we call progressive muscle relaxation. So again, as I've said, tension is a big symptom of when we're feeling anxious, that muscle tension. And, you know, I carry a lot of tension in my neck when I feel anxious. You know, I'm sure you probably are aware of where you feel yours. And what progressive muscle relaxation does is not only does it make us aware of that tension, but it gives us permission to tense and relax our muscles as well. So I would tend to start with, say, my left hand, for example, and I would ball it into a fist. Obviously, I'm doing that really tight. I can feel the tension running down my fingers, running down my thumb, and then I let go. And I can feel that tension just kind of drift away. I might do it a second time. Again, I might count to 4 or 5. I'm going to let that drift away. Next, I might move up my arm. So I'm just going to kind of put, you know, my forearm up to the bicep. There's that clench. Obviously, feeling that really tightly for seconds. I let that go. And you can work all the way, you know, obviously, again, if you go online and type in progressive muscle relaxation, there are probably hundreds of scripts, guided versions on YouTube, the works. You know, find one that works for you. Some start at the top of the head and move right to the feet. You know, again, just find one that you're comfortable with. The only caveat for progressive muscle relaxation, I'd say, is if you do have any difficulties with any muscles, so obviously be very careful when you tense your neck. For example, my legs aren't the best, so I'm very careful when I'm tensing those muscles. So just being aware of your own limitations with that, I think, is important to say. So this wasn't just an excuse for me to put like a Pink Floyd album cover in the slides. There's some really kind of emerging evidence that a third wave of CBT that we know as acceptance and commitment therapy can be really, really helpful for people living with long-term health conditions. And a good introduction to this is kind of this, because it's a lot about kind of metaphor and imagery. We're going to do a couple of exercises now, just to give you an introduction to it that hopefully will be helpful. I've done this with patients in the past who, you know, obviously I work with a lot of patients with various cancer diagnoses who come in, and understandably, as we've talked about, the power of those words, you know, the uncertainty of what's ahead, have a lot of thoughts. They're very scared. They're very anxious. They don't know what's coming next. And what I do is I get them to write all these thoughts down on a post-it, and I get them to put it on the wall in the room. And, you know, all kinds of things, you know, I'm scared. I don't know what's happening next. The self-critical thoughts, everything. Get it all on the wall. Now, a lot of old standing CBT techniques would be, right, well, let's challenge these thoughts. How can we challenge them? That's difficult in this situation, and it's not necessarily helpful. And I think, tying back to what Dr. Marshall had said about living with it and respecting it rather than fearing it, it's about looking at that wall, looking at your thoughts that are right there on the wall, and saying, yes, you know, those thoughts are valid. This is a scary thing. This is a difficult thing. You know, it's unfair that you're having to go through with it. However, can we look away from that wall for a moment? Can we go over here? That's still going to be there. We can, you know, it may be that the day go back, those thoughts are still going to be there. They're not necessarily going anywhere. But you don't have to spend the rest of your life looking at that wall. You could look at another wall in the room. You could go and do those things you love. It doesn't, I hope, you know, ideally, it doesn't have to become that sole focus in your life. So that's essentially what acceptance and commitment therapy is saying. A lot of it about being in the present moment. So I've just got a couple of exercises to kind of finish up, to kind of just sort of foster that and encourage it a little bit. a lot of it about this first one certainly is around self-soothing. So, you know, in times of distress, the way I look at it is, if you think about, like, if you think of our lives as a timeline, yeah. So obviously we're in the present, we're in the center of that timeline, we're in the moment. When we're uncertain, when we're anxious, when we're worried about the future, our mind is no longer in the center of that timeline, it's over here. If we're ruminating, if we're feeling low, if we're feeling upset, we're thinking about what's happened previously, we're over here. So a lot of these techniques are about bringing you back into the here and now. When I say here and now, literally second by second, you know, and being able to enjoy life for what it is. And one of the ways of doing that is to think of your five senses. So again, almost feeding those senses. You know, so in terms of sight, it might be, you know, you notice that your mind's wandering and it's like, you know, playing your favorite video game or reading a magazine or going for a walk into the woods nearby, whatever that looks like. Hearing, you know, listening to your favorite music, you know, listening to a podcast you enjoy. Obviously, there'll be suggestions for all of these. The exercise that I've got here is specifically somewhat about taste, but I'd say more about smell. Now, obviously, I know that I can't say everybody at the moment. So, you know, if this is something you just want to observe, that's fine. If there's something you'd like to try as I'm talking, you know, that would be great. So, essentially, you know, a lot of the exercises that I've done this with, do with the sultana. You can do it with any piece of fruit or food. It doesn't need to be a sultana necessarily. It could be some chewing gum. It could be, you know, whatever it is. And it's about eating it in slow motion. So I don't know about you, like, obviously I work at the NHS. I'm super busy. I probably just throw food in my mouth all the time and I barely acknowledge what it tastes like. So it's taking that moment and just eating it in slow motion, really taking your time. And I've done this in session with patients before. Focus on the taste and the texture of that fruit. How does it feel in your mouth? You know, obviously with the sultana, like, are there any juices coming out of it? You know, they're quite wrinkly. I think that's why kind of they tend to pick that. And you know what it is? It's about bringing yourself into the moment and really enjoying what it is that you're eating and really appreciate that. Now, what might happen, and this is a big part of acceptance and commitment therapy, you might have distracting thoughts come and go. And it's easy to be like, oh, well, Mike's asked me to do this, and my mind's going to this, and I'm really angry with myself. But that's okay. This is all just part of your experience. So just let those thoughts come and go. But always gently bring your focus back onto eating that fruit. And what that exercise demonstrates is it acknowledges that we can miss out on being in the moment if we're fixating on mood, anxiety, pain, uncertainty, all of these kinds of things. So, you know, again, me as an example, you know, wolfing me dinner down before my next appointment, you know, I'm not in the moment. I'm thinking about who I'm going to be seeing next. I'm thinking about what I've done this morning. I'm not in the moment. Yeah. So it's about taking that time, you know, be it with a sultana, a crisp, a glass of juice, whatever it is, and being in the present moment, letting those thoughts and sensations come and go without judgment, and just focusing on that present moment. So I'm just going to finish off with a little bit of a metaphor, really, which is one that I really love from acceptance and commitment therapy, and it made me think a lot in different ways about negative and anxious thinking, and it's about an unwanted party guest. So I'm just going to kind of tell this story and we'll kind of just let it unfold. So imagine that you're going to throw yourself a party, and you think to yourself, right, and all my favorite food, all my favorite drinks, I'm going to invite everyone. It's going to be a fantastic night. I'm really looking forward to it. And yeah, great, the party's in full swing. You know, you're really happy with how it's going. And then there's a knock on the door. And it's that one person, we've all got one, that one person didn't want to invite. And that one person thought they're going to ruin it if they come. And they're like, oh, just pop in. And you're like, no, thanks. You know, we're full. No, I'll just come in for 5 minutes. I'll just come in. And sure enough, they come in and they start eating all the food at the buffet table. And you say, right, no, come on, get out. I was afraid of this. Out you go. Back to the party. The door goes again. Oh, come on, no, just let me in. I'll be no bother. I'll just be over there in the corner. Then they start maybe insulting your other guests. They've blocked the toilet. They've, you know, eaten the rest of the food, got drunk and made a right fool of themselves. And you're standing there and you think to yourself, this is what I was afraid of. This is what I didn't want to happen. So you need to get out. Again, kick that person out. But this time, you're going to stand by the door. You're going to barricade that door. This person's not coming in. They're not going to spoil my party. I'm going to stay here the rest of the night if I have to. They're not coming in. There's two options you've got at that point. You could stay there for the rest of the night, but you're not going to enjoy the party. You know, you're going to be too busy thinking about that unwanted party guest on the other side of the door. Alternatively, and it sounds kind of reductive, but you could let them in. And yes, they might block your toilet. They might get drunk. They might be really insulting to your guests. But it's about you saying to yourself, well, this isn't what I had in mind, but this was my party. And I'm going to enjoy it regardless of what that party guest is doing. I'm just gonna let him do his thing. I'm going to enjoy myself. And so what that's a metaphor for essentially is that, you know, these thoughts can come and go. But again, if we're really stuck in terms of, you know, spending all that time thinking about something and trying to push that thought down, don't want to think about it, I don't want to think about it, and the thought keeps coming back, it's going to be really, really difficult for you to enjoy the present moment, to enjoy what's going on. Whereas if you can say to yourself, well, this is part of my experience, it's not quite what I had in mind, but I'm not going to let it ruin my party. You know, and I guess that's the takeaway. Do you know what I mean? And it ties in a lot with what kind of the other speakers have said today, that you know, this is something that you can still live a really kind of rich and fulfilling life with. You know, so don't let it ruin your party, I guess would be, if there's anything to take away from what I said today. That's very, very much an introduction. Do you know what I mean? And I'll be around next week, obviously, to answer any questions people have got, maybe to dive a little bit deeper. In terms of psychological support that's available kind of nationwide, because as Helen said, absolutely correct, like different areas kind of have different setups and what's available in some areas than others. So I know psychological support for cancer patients in County Durham and Darlington isn't fantastic, quite frankly. You know, so we can, every patch of the country has what's known as a talk and therapy service, formerly known as IAPT. So we rebranded, so we all had different kinds of names. This year we've rebranded, so if your service hasn't already, they'll all be rebranded to talk and therapies and then your area. So the GP should be aware of kind of what your local IAPT or talk and therapy service is called, and they can make a referral on your behalf, or you can make a self-referral. Follow initial assessment, you'll be placed on a waiting list for an evidence-based intervention, most likely cognitive behavioural therapy, and all services like mine should have like a long-term conditions pathway. So there should be people who are kind of trained specifically to work with people living with a long-term health condition. There's also, if you felt like you didn't need that kind of structured support, you know, there's some GP practices that can offer kind of less structured support through like a mental health nurse or CPN or something like that. So there is that support out there. But I guess that's pretty much it from myself. So thank you for listening to me. And thank you for having me as well. It's really appreciate it.
Thank you very much, Mike. Really, really interesting talk. The sound was a little bit off at times, which actually made me concentrate a bit more. And I did find my breathing changing as you were talking then. And I've got the attitude that nothing's going to ruin my party today, considering the issues that we've had with the webinar. So listen, thank you to everybody for their patience. I've got a few slides that I wanted to run out on. There are a couple of questions there left floating, and I'm not sure if we've really got time to address these. Just to allude on what we're saying, and I'll touch on the slides, we are having the National Watch and Wait group with everybody, clinicians and speakers attending, so that we can go into great depth and a lot more depth with everybody. And we will be circulating this to all the information and registration to everybody that has registered or attended today. Scott and Helen and Mike, I realise just how busy you are. There's no real need for you to stay on whilst I share out these slides if you don't want to. I'm just going to run these slides. So before I share the slides, I just want to say thank you for your attendance. Thank you for your support, and thank you for your really valuable information. I'll just quickly share my screen now. And audience, there are a couple of questions out there. Maybe one I will just go to, which was a clinical one that I can see with regards to Mike, you talked about, Scott, you talked about the shingles vaccination, and I didn't quite pick up on the discussion there about the antivirals, if you were on antivirals against shingles reactivations. And there's a question there about, should a person be on those continuously or only have those at the point of activation? And
so if
somebody's immune compromised for whatever reason. So
if you've got immunocompromised, and if you've suffered shingles, recommendations would be that you remain on long-term acyclovir prophylaxis. So treatment dose for shingles is 400 milligrams 5 times a day. Sometimes we have to use higher doses to get things under control. Preventive doses, once the episode has passed, does vary between different hospitals. I use 400 milligrams twice a day. Some people use 200 milligrams 3 times a day, but you have to take it every day for it to be effective. Sorry.
Thank you very much, Scott. I think we'll leave questions there. Any questions that are still left floating that we can take to the meeting on next Wednesday, which will be a virtual support group meeting, and you'll be able to talk and speak to everybody face to face, virtually though, yeah, remotely. So you'll at least be able to see each other and participate. I'll just run out some slides very quickly, and I'll literally skim through those if everybody's got the patience for those. Just to remind everybody that this session is being recorded. All of the information that's been provided on everybody's slides will be edited together so that you can revisit these before next week's meeting, or just revisit at your own leisure. And these will be posted on our YouTube channel and available through the website. Please bear with me while I try to find the slides, end slides. Here we are. Okay. I think that should be visible now, and it would appear.
Yes, I can see them.
Right. Apologies, I have notes on my desk here. Apologies, I think I've shared the wrong slides. I cannot believe this. I'm having a bit of a problem with my eyesight today. I do struggle with just the one eye at times. Okay. Just quickly touching on what Helen had already led to, please do contact the charity or use charity resources that can also help you with issues that you're looking to gain information or further support or clarification with issues. So the charity provides information sources, webinars such as this webinar across a range of topics. We have the regular newsletters and the quarterly magazine. You can also choose to listen rather than watch through podcasts. Social media we're very active on, and the website is a mine of information. And there's a lot more information around mindfulness and other coping strategies, for example, that can help you with coping with living on active monitoring, especially the information. Booklets, patient information booklets are invaluable. And we do carry quite a range of booklets, and there are specific booklets written, and very recent ones on CLL, which are excellent, as well as information with regards to understanding active monitoring. I touched on the quarterly magazine that can be reached, and you can subscribe that through the website. We have a helpline where, as Helen touched on, where we have nurses available. That service is also available through WhatsApp if you wanted to be able to contact us virtually and didn't want to talk on the phone, or that wasn't the appropriate route. All of our support books, as Helen touched on, we also at Leukaemia Care provide a national support group network, both local and disease specific, or maybe more broad hematological. And we also have our national support groups, which I'll come to in a moment, that is following on from this. Welfare advice and advocacy support are provided by our advocacy officer, Sophie, who's been very kind and helped today with this webinar. And if, you know, for welfare advice and coping with financial challenges you may be experiencing at the moment, we have a welfare officer who will be there to support you as well. Online forums, critical, Facebook groups, and the buddy scheme. You know, that's part of that connection, connecting with others that have got lived experience and are understanding and have maybe been living with and understanding what you're trying to understand on active monitoring. You know, that patient peer connection, I myself as a patient found invaluable, and that is one of the greater ways of working things through and understanding how to cope with challenges. We also will have a counselling fund that Helen touched on, and I think I've got a bit more information. This is the key information to follow on from this webinar. Everybody that's registered or attended today will receive the video and information in regards to this group. Scott is attending and Mike is attending, and Helen's colleague Leanne will be attending to provide this clinical nurse perspectives, and that will be a more conventional peer-to-peer support group, patients coming together and everybody being able to share and explore what's been discussed and explore the topic. So please do pencil that in your diaries if you're available, and the right time, 3:30 next Wednesday. If buddy schemes, again, a really important way to be able to connect with others that have got lived experience, where you can connect and understand and talk through together how to manage the issues that you may be trying to, or that may find challenge, or just to have somebody that understands, that gets it. You know, our buddies are fully trained, and you can reach our buddies through the website or by calling our helpline. We have a counselling fund where you can apply for 6 sessions with an accredited counsellor, which is something there. The services, for example, that Mike was alluding to, this could be a route to give you access or to gain access where you may be challenged through your GP or other areas. The charity can offer you the support to actually gain those talking therapies that Mike was sharing. I just talked about our advocacy caseworker. Sophie is there always to answer your queries. And that could be anything with regards to how your healthcare is delivered, issues you may have connecting with others, could be with regards to, how you're coping or information that you need, anything along those lines. Please don't hesitate. If you're struggling in those areas, get in touch with us. You can do that through the website, or you can contact through the helpline. And last but not least, we all have to sustain everything we do. If you're a fundraiser, if you're somebody that actually likes activities, then there are many ways you can help raise a few quid funds to help support the charity, to help support others. And we'd be extremely it would be extremely generous, and we'd be very appreciative if anybody was interested in that. You know, live well if you can with your watch and wait. Don't live and worry. It can be a very long journey, and it can take a bit of time for a lot of this information to sink in. And there are a lot of challenges. You know, winter's coming. There are worries out there that you may have, but just talk to other people. Connection. I think that's a really key thing. And, you know, if you want to meet others, another way to do that is fundraising in the community, bringing a group together, that kind of initiative. We're very active on social media, and you can probably follow today if you're that like-minded. Look on social media. Today's World CLL Day. There's a lot of activity out there that's signposting to resources on this very topic. You might find that helpful. And I'll leave this slide up for a little moment, just so that you've got our helpline number and you have a website address and our support resources email address. I'd like to just thank everybody again for attending, and apologies for the time mix up earlier. And I really do appreciate, Scott, you going over it. Sometimes, I don't know, in teaching circles, people say if you say things 3 times, that's when people are able to absorb all of the information. I definitely absorbed all of the information, so really appreciate it. Just to let everybody know also that the slides in full are also going to be available to you, so that you can actually look at some of that closer detail, for example, that's on Scott's slides with regards to timings when we were asking questions around vaccinations, etc. So just like to, I'll stop my share here. And I would like to say thank you to everybody. Thank you to our panelists. And please do, if you can, next Wednesday, join the National Support Group at 3:30. You can then chat yourself to Helen and with Helen and with Scott and with Mike and with each other, and share advice, information, how you manage the challenges, and have a moan, have a grumble. It doesn't always work. Sometimes you can't always be positive. You can't always live for that moment in the day, but you can take those problems with you to the meetings and share them with others if you're able to do so, because you're not alone. Don't be alone. Don't walk alone with these issues. That's the point. Connection, get good information, reliable information, go to the charities and reach out for support. Thank you, everybody. Thanks, panelists. It's been a longer session than we'd planned, but really appreciate it. Thank you so much.
Thanks, really good. I look forward to next Wednesday.
Yeah, I'm sure. I might see if I can drop in, actually. Cheers. Even if it's to be berated. Thanks, everybody. Yeah. Cheers. Bye-bye.
Bye.